So today is our week 7 call, and we are going to kind of just do a filler recap of some of the stuff that we went over in training. And then, really, from kind of here on out, it's more just kind of answering any questions y'all have. Of course, we have our marketing homework at the very end, but really, the last 2 calls are really just kind of dedicated to y'all to kind of see what questions, as far as MFL goes, as far as AR, any type of operational questions, anything that you would like to talk about. That's really, it's an open forum for you. So I'm going to do a quick screen share. And let's get started. All right, so this is the content that we're going to be going over today, and let's jump in. So we're going to do this quick filler recap. Let me click on here real fast, and it's going to take me, whoop, take me to the wrong page. Give me 1 second. Here we go. So this is the PowerPoint presentation that we go over in our filler training. Obviously, I'm not going to go over every single thing again, but I'm going to try to highlight some of the big things that we kind of go over in this training. So whenever you are talking about filler, you need to make sure that you are really comfortable with the big vessels that are in the face. And with those vessels, the main one is going to be the facial artery. So if you kind of follow the normal anatomical path of the facial artery, you start at the external carotid, kind of comes up, and then it dives directly in front of the masseters where it comes out of a little foramen. So this is the facial artery as it travels up. Then you hit the angular artery, and it continues on up to the supratrochlear artery. Feeding the lips is going to be the inferior and the superior labial artery. Feeding the majority of the mid face is going to be the transverse facial and the infraorbital artery. Now remember that the infraorbital artery comes out directly below the pupil on average for most people. So that's why whenever you're doing any type of mid-face filler, you want to make sure that you do not go directly below the pupil, because that's kind of a no-go area. The infraorbital kind of comes out of a little hole right there, a little foramen. So you want to make sure that you avoid that. And then you have your nasal arteries, and then you have your mental arteries. So the the nose and the nasolabial fold and the glabella areas, those are really kind of areas that are a lot of no-go areas for filler. You don't want to be putting any filler in a glabella. You see liquid rhinoplasties all over Instagram and TikTok. They are extremely dangerous. The only time I'm ever okay with it is if the injector has a ultrasound on hand and it is ultrasound guided, because the majority of vascular occlusions that cause blindness are from noses and glabella. So always just kind of keep that in mind. And with MFL, you are not allowed to do liquid rhinoplasties, glabella, or frontalis as far as filler goes. So these are the different layers of the skin. It's important whenever you're injecting filler that you know what layer you're going to be injecting in, and it helps you choose the appropriate filler for that layer. So if you have a very low G prime product, you're going to want to lay that filler into layer 1 or layer 2, where if you have a really high G prime product, that needs to be in a deeper layer of the skin. So you want to kind of be super periosteal for some of those higher, kind of thicker G prime products. So these are the different fat pads of the face. And as we age, starting out around the age of 35, your body stops producing its own natural collagen. And at the age of 35, your fat pads will start to slowly separate and disintegrate. So that's why you kind of get that volume loss. So the purpose of fillers is to put volume back where volume once was. It's not to try to make a whole new person or try to rebuild a face. You want to try to rejuvenate the face and kind of give that a natural volume back. So you never want to go too much whenever you are doing filler, and filler does have its limitations. This is where in our training we usually do some ultrasound mapping in the bigger trainings. So these are all the different areas that can be treated with filler. Obviously, there are a ton more, but these are kind of the big ones that people will do for, they'll do lips, you can do cheeks, nasolabial fold, hands, jawline, chin. You can do some face contouring, some facial balancing. You can do a lot of different things with fillers. Now, there are different types of fillers or that are underneath the umbrella of the term fillers, and those are going to be the HA fillers, the calcium fillers, and the polylactic or Sculptra. Now, all of these kind of act a little bit different. Hyaluronic acid is going to be the majority of what we use here at MFL, and those are things such as the RHA brand, the Restylane brand, Versa, things like that. So those are going to be the RHA fillers. Sculptra is another filler that we do carry. You do have to be specifically trained on Sculptra. So if you have taken a previous outside training and would like to start offering your patients Sculptra, you absolutely may. Or if you would like to learn more about it, we do host some trainings every now and then in the bigger training cities such as Houston and Dallas, and we do some Sculptra trainings for those injectors. What is G prime? G prime is essentially the thickness or the viscosity of the filler. That's the easiest way to kind of describe it to your patients. A lot more goes into it. It talks about cross-linking, talks about how like the molecules are strung. So a lot of things kind of goes into the definition of G prime. However, when I explain it to patients, I really just kind of let them know it's the stiffness or the thickness of the filler, so they know it's a high G prime product, it's going to be a thicker product in general. And if it's a low G prime product, it's going to be a thinner product. So this is the G prime chart for all of the current products that we carry here in the US. So it has the entire Restylane line, it has the RHA line, it also has Belotero and the Juvederm line on here. So you can see the highest G prime product out on the market is going to be Restylane Lift, and the lowest G prime product out there is going to be Refine. Now it's really interesting because Silk is also up there over on the high G prime side. However, Restylane Silk is a very unique product because it is such small particles that while the stiffness of this filler is very, very like very high, very up there, since the molecules are so incredibly small, it cannot be laid in a very deep plane. It is meant to be laid more superficially. So it gives a lot of structure. It's a beautiful product to put in lips, but it does love to swell. So Restylane Silk is definitely one of those products where if the patient is really nervous about swelling, you really want to stay away from Restylane Silk. Okay, so whenever you're doing your physical exam and your interview, these are the types of medical questions you want to make sure you're asking your patients. If they're allergic to lidocaine, because all of the products are impregnated with lidocaine, they do need to be aware of that. If you do have a patient who is allergic to lidocaine, you can specifically request that you have a product that is lidocaine free. Note that not all of the products come lidocaine free, so just know that from the manufacturer. You also want to know if the patient has undergone any type of cosmetic or aesthetic procedures. If the patient, for example, has a chin implant, you need to know kind of what's going on underneath the skin. I had a patient one time, she came to me and she wanted to get her lips done, and her lips look a little off to me. And so I went ahead and I had the ultrasound with me. I put the ultrasound on there and I could not see anything in her lips. I couldn't see any of her anatomy. I couldn't see any vessels. It was the craziest thing. And she had said it's because she had silicone injected into her lips like 15 years ago. Obviously, I elected to not treat this patient because I could not appreciate any anatomy in there. So she did end up having to go to a plastic surgeon for her procedure, but they actually turned her away as well. And the only reason why I know this is because she is one of my friends. So good to know. You also want to know if they're taking any type of medications or herbal supplements. If they have a history of cold sores, you do need to call them in Valtrex 2 grams PO BID if they are getting their lips done or any type of filler around the mouth because it can cause a herpetic outbreak. The worst thing that you can do is do this beautiful lip filler on a patient and then the next day they break out in a cold sore and it moves that filler around and now the patient has some asymmetries. So if they have any history at all, you do need to make sure that that medication is called in for them. Again, that's Valtrex 2 grams PO BID times 1 day. If they are pregnant or breastfeeding, they're obviously a no-go. And then any autoimmune disorders, this is not a no-go kind of question. It is just an educating point that you need to talk to your patients about. You know, with autoimmune disorders, it's really difficult to say how filler is going to react once you inject it into the patient. Sometimes the body can attack the filler and cause kind of some delayed nodules. So you really need to educate your patient if they do have lupus or any of those kind of other autoimmune disorders that they are at risk for that because of their medical history. For the physical exam, you want to assess the skin texture and the quality of their skin. If they have any type of open wounds, any type of scarring, any type of lumpy or bumpiness, anything that looks abnormal, you need to make sure that you document it in the patient's chart. You also want to note any facial asymmetries that the patient will have. Everyone has asymmetries. Some patients will sleep on one side of their face, and so one side of their face will be flatter. So if you're trying to do a mid-face correction, you're going to have to point that out to the patient. That way you can note, hey, I have to make you even first before I can kind of fill, to give you more volume. You want to note wrinkles, any volume loss, bone structure, the contour, and obviously the vascular health. I always kind of tell my novice injectors and even my experienced injectors, always feel for pulses whenever you are about to inject someone, especially in the lips or if you're doing someone's chin or jaw. You want to make sure that you're feeling for that pulse and kind of put a little X there. If you're going to be doing their lips, feel where those pulses are so you can appreciate if it's going to be lower into the lip, if it's going to be above it. That way you can kind of have an idea of what's going on underneath that skin. This is going to be the pre-treatment checklist. Obviously, this is something that is ideal, but you have patients that will come to you that drank a cup of coffee that day or had a glass of wine at dinner the night before. And may or not be honest with you, but these are the things that you want to go over with your patient before you inject them with filler. The big thing on here is going to be with the vaccines. This came out during the COVID vaccine. What they were showing that was happening is after the patients were getting these vaccines, it was within that 6-week window that it was causing a immune response, and it was kind of causing the patient's face to have pretty severe swelling. So the kind of new rule of thumb is that we say no vaccines for 6 weeks before or after filler. Now, these are going to be the contraindications, and these are the no-go. So if you have a patient who's on any type of blood-thinning medications, warfarin, Lovenox, Xarelto, Eliquis, any of those, they're an absolute no-go for filler. If they have an active infection, you do not want to be injecting through an active infection. If they are pregnant or breastfeeding, or if they're allergic to lidocaine. So let's talk about some common side effects. Bleeding and bruising, swelling, lumps and bumps. I usually tell my patients to not love or hate their filler for at least 2 weeks because the inflammatory cascade takes around 2 weeks to kind of go through its entire cycle. So you want to make sure that all of the inflammation is gone before you go and try to dissolve or add filler or anything like that. Tenderness is very common, and a herpetic outbreak can happen if the patient is not called in the appropriate medication. And again, that medicine is Valtrax 2 grams PO BID times 1 day. I know I'm kind of going through this rather quickly. This is just a filler recap, but does anyone have any questions so far? We're about halfway finished with it. Nope, perfect. All right. Okay, so let's talk about those lumps and bumps, especially when you're doing a patient's lips. The worst thing that you can do is, you inject a patient and you don't educate them on what to expect after they get lip filler. Please educate your patient that they will have swelling, they will most likely have some bruising, and lumps and bumps can be normal up to 2 weeks. We typically tell patients if they do have a little lump or bump, wait that 2 weeks, and then if they still have a little residual lump or bump, I will usually tell them to kind of take it between their fingers and kind of massage it twice a day while they're brushing their teeth. And I have them do that for about 2 weeks. And if that does not take it away, then I would go in with some dedicated Hylenex and dissolve any kind of residual filler that I feel that is laid too superficially. So that's kind of our rule of thumb. So kind of more watchful waiting. I never jump to straight wanting to take Hylenex to a patient's lips if I've just injected them. So really this kind of wait 2 week and then massage for 2 week at home. That takes care of 99.9% of any lumpy or bumpiness that I've ever seen. So let's talk about some major complications. Those things are going to be like cellulitis, obviously vascular occlusions. You're going to have hypersensitivity reactions and delayed onset granulomas. So let's talk about the phases of a vascular occlusion. On average, each phase is around 12 hours or so. So that very first phase is going to be blanching. That second phase is going to be a reticular lacy pattern. This is where you have kind of some erythema and some blanching, and it will follow the vessel. At stage 3, that's when you'll start getting some vesicles. Unfortunately, this is when some injectors will think that it's just a simple herpetic outbreak when it is just a progression of a vascular occlusion. And then you will start to get initial skin breakdown on stage 4, and stage 5 is going to be full thickness necrosis. The very last phase is stage 6, and this is the healing phase, and it does have to heal from secondary intention, meaning from the bed of the wound on up, and it can take up to a year for this to happen. If you do have a vascular occlusion, you have an entire team behind you. We have ultrasounds um, needed if we need to do some dedicated Hylenex via ultrasound. We actually have an entire set of a company that only helps with vascular occlusions. I am the lead for that. And the majority of actually all of our patients have always been outside clinics that will contact us. The way that we teach filler and the way that we teach to aspirate, we've only ever had 2 VOs in our company. The first was actually by one of our educators, and it was just, she got struck by lightning, and it was a compression VO. It was not an intra-arterial VO, which was great. And the second one was Brian, and again, it was a compression VO, and they were able to massage it out at the time while they were injecting. So no Hylenex was needed. So, which is awesome. And we have a little over 180 injectors in 3 states, and we've only ever had 2 scares in the 9 years since the company's been around. So I kind of touched on this a little bit of the 2 different types of vascular occlusions. So the first one is going to be an intra-arterial occlusion, and this is where you are injecting accidentally into a vessel. And the second one is going to be a compression vascular occlusion. Now, an intra-arterial occlusion is going to occur while you are injecting, where a compression vascular occlusion can occur, 1, while you are injecting. If you get too close to a vessel, it can compress it, or 2, from swelling or from inflammation. It can also cause a compression VO. So that is kind of where a lot of education on your patient of what to look for. Now, whenever I ask injectors what is a sign of a vascular occlusion, the very first thing that I always hear is pain. Now, I will tell you, pain is plus or minus. If a patient does have pain, obviously it's very concerning. But if the patient does not have pain, it does not mean that it is not a VO. So just know that. Not all VOs are super painful, and a lot of patients will have different pain tolerances. So please don't let pain, if the patient is not in pain, that is your simple ticket of, oh, this is definitely not a VO, they're not in pain. But if they are in pain, you definitely need to listen to that. So 2 different types of vascular occlusions, but regardless of the type, this is how you are going to, this is the product that you're going to use to fix it. This is Hylenex or hyaluronidase. Hyaluronidase or Hylenex is the enzyme used to dissolve all hyaluronic acid fillers. What's really unique about Hylenex is that if you have an allergy to bees, like a true allergy, anaphylactic allergy to bees, you are more likely to have an allergic reaction to Hylenex. Now, back in the day, we actually used to do patch testing for Hylenex because of this. But what we have found after kind of going through our vascular occlusion protocols and talking to different specialists, specifically to allergists. So the way that med spas were doing patch testing for Hylenex is actually incorrect. So the true way to do a patch test for Hylenex is you have to inject it, and then you have to wait 2 weeks before you actually will go in and do any type of dissolving. Now, a lot of clinics, what or at least what we were initially taught, is that you could inject the patient, wait 15, 30 minutes, see if they had a reaction. If they did not, we would inject. This is what we were taught years ago. We have now kind of got away from patch testing. If the patient tells you they are allergic to Hylenex, we must believe them. If they are allergic to bees, I will go ahead and I will pre-treat them. And this is only for emergency situations. If a patient does want to have some filler dissolved just because they don't like it and they are allergic to bees, I would opt to not do it at that point. But during an emergency situation, you would have to pre-treat the patient with some prednisone, Benadryl, and Pepsid. This is our vascular occlusion protocol. You're going to stop injecting and then you're going to do aggressive massage to the area. If it is a compression VO, this should take care of it. If it is an interarterial one, as long as you're not injecting a large bolus, you should be able to try to help move some of that product around. You are then going to flood that entire area with Hylenex, undiluted Hylenex. I know some practitioners will dilute their Hylenex because it burns. This is an emergency situation. I need this product as concentrated and as powerful as possible to get this patient out of an emergency complication. So just let the patient know this is going to burn. After you flooded that entire area with one vial of Hylenex, you are then going to do aggressive massage again. If you are still not getting color change back, you will then need to cannulate the vessel with one vial of Hylenex. You will pull it up into an insulin syringe, and especially if it's in the lip, you can evert the lip and you're going to aspirate until you get a positive blood turn, and then you will be injecting that one vial of Hylenex. You will do warm compresses, start the patient on aspirin. We will then call the patient in antibiotics and start the patient on hyperbaric treatment. It's a minimum of 4 treatments. Now let's talk about treating infections. So for infections, these are the 2 types of medications that we're going to be calling in. We're going to be calling in some steroids. Typically it's prednisone, 60 milligrams, PO, Q day times 3 days. And the second one is going to be one of those 4 antibiotics. We are trying to treat strep and staph, and those are kind of like the big heavy hitters for those kind of 2 bacteria. Okay, so we're going to play a little fun game. So go ahead and unmute yourself if you can. And we're going to go through these pictures and you're going to let me know if it is a vascular occlusion or if it's just a bruise. If it is a vascular occlusion, we're going to talk about what stage it is. So let's talk about this one right here on the very left-hand side. Is this a vascular occlusion or is this just a bruise?
Vascular occlusion.
Vascular occlusion.
This is a VO. This is a classic and most likely interarterial VO. They have most likely, or they've hit the inferior labial artery when they were injecting. This is going to be a stage 1 VO. So they simply only have blanching. So stage 1 vascular occlusion. So let's do this next one right up top right here. Is this a vascular occlusion or bruise?
Bruise.
Simple bruise, right? So bruising can look pretty gnarly. It does not have any blanching. It doesn't have that reticular lacy pattern. You don't see any vesicles. There's no skin breakdown. There's no full thickness necrosis. So this is a simple bruise. What about the one right next to it?
Bruising.
Bruising as well, very gnarly bruising. And it's kind of around the entire lip as well, kind of uniform bruising. So she did bruise pretty bad, but this is just simple bruising. What about this large picture on the side of the cheek? What is that?
Vascular occlusion.
What phase do y'all think that is? Phase 1, 2, 3, or 4, 5?
Erythema, the stage
Yep.
2.
Yep, this is going to be a stage 2. So this is erythema with some blanching. So this is what that reticular lacy pattern looks like. What about the bottom one in the marionette lines, bruise or VO?
Bruise.
Yep, bilateral bruising. And then the very last one with the nose, what does that look like?
VO, it's vesicular.
Yep, VO, and you're starting to see some vesicles. Very good. All right, so this is our retinal occlusion protocol. Now, just know if you are ever injecting and the patient says all of a sudden, I can't see out of my right eye, time is muscle, very similar to a heart attack. It is ideal to have treatment within 15 minutes. However, the enzyme has to be laid by an ocular surgeon. So the patient must be taken to a main ER where an ophthalmic surgeon is present where they can lay the Hylenex and a retrobulbar injection. That is not something that we are trained to do. So this has to be done by a specialist. The way that we prevent these kind of big, bad, scary things from happening is going to be to aspirate. So this is our retinal occlusion protocol, but the next slides, I'm going to talk to you about how to prevent all these kind of devastating things from happening. Here we go. Okay, so in order to keep yourself safe, we teach every single injector to aspirate with every single injection point, at least for 6 seconds. And I know that sounds very annoying if you have not taken our training before and you're like, oh my gosh, but I learned the Julie Horn method and they told me I don't have to aspirate. That is false. I have watched on video several times and I have helped several outside companies where they were filming themselves doing the Julie Horn technique and not aspirating, and they caused a VO. So you absolutely can cause a vascular occlusion with the fencing technique. So please aspirate. It takes literally 6 seconds. It not only protects your patient, but it also protects your license. So it's 6 seconds with every single injection point. And it's not going to guarantee that you are not inside of a vessel, but it's like wearing a seatbelt. Why not? You also need to know your anatomy of where you are injecting. And while you are injecting, you need to make sure that you are injecting slow and you are watching for color change. You never want to lay more than 0.2 of product at any point in anyone's face. And the only time I ever lay more, I ever lay 0.2 is in the mid face, and it's that very first mid cheek injection, or if I'm on a man's chin. Other than that, I'm only ever laying 0.1 at any given time in any given injection point. So this is the pre-procedure checklist. You want to obviously do your patient assessment. You want to do your informed consent. You want to set up everything for the procedure, and then you want to prep the patient as far as cleaning the patient, marking, all of those kind of things. Post-op treatment, you want to tell the patient to avoid strenuous exercise for 24 hours. A cool compress can be applied, no ice directly to the area. No makeup for 24 hours, no facials for 2 weeks, and they can use arnica, either the sublingual tabs or the gel for bruising. Okay. And that is the quick filler recap that we go over in our training. Do I have any? Okay, I was just checking the chat. Do I have any questions for our filler recap? After the 90-day probation, are we doing another hands-on? So after it's not necessarily 90 days, it's once you hit 8 patients. So once you hit your 8 patients, you are able to get checked off with filler, and it's not an additional filler class. It's you just have to inject filler in front of one of our trainers again. This is required by our supervising physicians. They want us to watch you inject filler one more time. You will bring that patient to that to that checkoff. The patient only pays the model fee, which is $125 per syringe, so significant savings to the patient. So it's usually not difficult to find takers for it. But no, it's not an actual dedicated class. If you have already kind of gone through our class, that's your didactic. You have free access to rewatch any of those videos, and then obviously you have your PowerPoint presentations. But it's not another class. It's just a simple checkoff. And it's as soon as you hit that 8 patient, you will reach out to me and we will get that set up. So please reach out to me specifically, and I will help you get checked off on your filler. Any other questions? Bianca, what questions do you have?
So when it comes to the telemedicine calls, do we have to do a telemedicine call for a new patient for microneedling or dermal peel?
Yes.
Okay. And then also, if it's the same patient as, the last time and they want to do a different area of Botox, we also do a telemedicine call for that, correct?
Correct. It is not like the hospital. And I think this is where a lot of nurses kind of get frustrated with telemedicine. But with telemedicine and aesthetics, it has to be perfect.
Yes.
It can't be like in the hospital when I write an order for 4 milligrams of morphine. The nurse in the ER, they have the ability to go, oh, the patient's blood pressure is a little soft. I'm only going to give them 2 milligrams of morphine. And then I'll, wait an hour, see how their blood pressure goes, and then I'll give them another 2. Unfortunately, the aesthetic world is not like that. It has to be exactly what they are doing. That autonomy does not translate outside of the hospital with aesthetics.
Okay, thank you. And then for traceability, I was doing my traceability and it was a little bit off because I was doing the traceability for my launch party and it was a little bit off. So I should just contact Stephanie for that or
Yeah.
the nurse practitioner that was there with me because it was with one of her vials that she let me have
Mhm.
as well.
Okay.
So should I contact her as well?
Yes, contact her first, and that way, because with traceability and whenever it being off, there is always evap and like normal evaporation, and we know that. So just don't fret if you're like, hey, it's off by a few units. We know that evaporation happens, even just from like flicking it. You can lose some units. So please don't stress out about that at all. But yes, whenever you get it from another injector, and if you find that the numbers are off, please go with them so that can be corrected, and then y'all can all kind of get with Stephanie so those numbers can be corrected on your side.
Okay, thank you. And then with just one last question, sorry.
Yeah,
I actually hit my eighth client already.
awesome.
So yeah, I thought also that we were able to attend one filler class, but like you said, just to contact you and just I guess do a one-on-one with
Yep.
one
Where are you
client
located, Bianca?
and Katie.
Okay, perfect. Yep. So you'll actually come to my house to do that training.
Okay. So
Yep.
I just have to get one client and then
Yep.
we'll go to your house.
Exactly. Yep. So it's just like
Okay.
a normal kind of concierge setting. You come here, and then it can be you can bring as many clients if you want to practice on, and then I kind of do some one-on-one training with you.
Okay. Would there, I might have somebody, but their age 67. I don't know if that would be,
It
should it be someone?
depends. It depends on the 67-year-old's anatomy, right? Because you can have some 67-year-olds who are playing tennis every single day and they look like they're 25. And then you can have some who look like they're 80. So if you don't mind sending me a picture, I can kind of give you a yes or no of if they're a candidate for it.
Okay. Thank you so much.
Yeah. Do you have my cell phone number?
I believe so. Yes.
Okay, perfect.
Thank you.
Yeah. Any other questions? Perfect. Okay, so let's get back into our week 7. Okay, so let's go into, does anyone have any specific questions regarding aesthetic record?
I have a question about the alley points.
Oh, Allie's awful.
Yeah, so it's back from my launch party. I had one client use it, and Tanya and I couldn't figure out that day
Yeah.
how to put it in at all. So I had taken screenshots and photos of her Ally account, and Tanya had told me to send that stuff to Bernard. Is that who we send it to still?
Yes. So, well, okay, so Allie changed their program. So they no longer offer money off. So it used to be if they had 200 points, it was $20 off. They completely scrapped that program. And this happened about maybe a month ago or so. So the new program that Allie has is every time you get injected, you earn points. You get 200 points, and you can earn free product. So once you hit, I believe it's 1,000 points, you earn one free syringe of Juvederm filler. Once you hit, I think it's 1,600 points, you get 20 units of Botox free. However, with unless you are doing cool sculpting or you are getting breast implants, there is no obtainable way for and patients to get all of those points to receive free product because they do not roll over. They expire at 1 year.
Okay.
Yeah.
Just because the points didn't show up from her appointment.
Okay.
Um,
Yeah, yeah. Email Bernard and then he can log it for us for her.
okay. I
Yeah.
did send it to him, so I haven't heard back. I'll just follow up with him.
Yeah, yeah, follow up with him because he was taking a little leave of absence. His
Okay.
daughter was actually in the hospital. So
Oh,
yeah.
okay. I will follow up with him.
Yeah, perfect. And then if you send him an email, do you mind CCing me on it so that way I can kind of be in the loop with you as well?
Yeah, absolutely.
Thank you. Okay, any other questions with aesthetic record or any type of MFL operations at all? Perfect. Seems such a good teacher. All right, let's go into, I think somebody have a chat. Da, da, da. Thank you, Mary. Okay, so let's get into our homework for Week 7. So this week you're going to do a Facebook or Instagram live or reel. And you are also going to be posting a before and after of cheek filler. And I already have that graphic for you, so I will post it. And then the very last thing that you're going to post this week is you are going to do an education post that you will make up on your own about how the face ages. Again, the purpose of all of these kind of marketing homework is to get you used to the different types of things that you have to do to market yourself. Now, once you finish these kind of 8 weeks, you need to continue doing this because this is how you build your own personal brand. And in aesthetics, it is very important that you build your own personal brand. So I am just giving you different examples of different things that you can do. I do want you to continue your social media following, and there are 2 more injectors that I want you to follow. Again, these injectors, they do some advanced things. Actually, one of them does a lot of liquid rhinoplasties, which I don't love, but she is very good at injecting and does a lot of education stuff. So I want you to continue kind of being a sponge and try to learn as much as you can from anything and everything that you can get your hands on, any type of free trainings, free education. I am always here for any type of, anything I can get my hands on to expand my knowledge. I am always here for it. So that is going to be this week's marketing. Does anyone have any other questions for me at all with anything? Sounds good. Well, I will let y'all enjoy the rest of the evening. I know that it was a little bit longer of a call. The filler recap is always a little long, but if you ever need anything, please feel free to reach out to me, and I will see everyone back here for our final week of week 8. Bye, guys.